Okay, okay.
Is it a long case or?
I guess it's a long case. Let me go for it first. I made poly and LGA separate, so you want to do LGA. That will be an SPT or structure discussion. That has circuit. No, I will put a long case of poly and then we will do. Let's start. Don't worry, it will be LGA, okay?
Okay. This
As
is
you know,
this
guys,
is structure discussion.
yes. Just wait for a second. Let me go out from this. Just open the PowerPoint. I'm sorry, I closed it. Just wait for a second. No, that's before. I just wanted to show the history template for all because I can see the students are being confused in it many times. Let me open it in the PowerPoint. I will share the screen. Just wait a second because I wanted to take that history slide that will help you. Okay. So before going in, I want you to remember this history template for any obstetrical and for any gynecological patient. The long case, this is the long case template. The structure of the long case, you all know. Show from crunch. Okay. The long case structure, you all know. There is a cubicle. When you enter, you have total 25 minutes. There is a one long case, either gynae long case or obstetrical long case. I'm repeating the things for those who have joined us recently. One obstetrical, one long case. There are the two examiners sitting, and there one candidate and one patient. The moment you enter into the cubicle, your time count starts. Like from 25 minutes, it starts. So there is a table in between. There is a scenario. Usually they don't give much details in the scenario. Just there will be a patient about the presenting complaint or certain risk factor. Usually you have to ask the risk factor, but sometimes they give the risk factor. And after that, there is long line. Like they will assess you in four domains. Information gathering is your history. They assess you the communication with your colleague and with your patient, like how you explain your patient. If examiner asks you to explain your patient, and with your colleague is multidisciplinary team, like relevant to that case. For example, if there's anomalies, your relevant is fetal medicine unit, so you have to communicate with the colleague. These are information gathering, communication, patient safety. Patient safety is like if blood group is negative, remember that. If she is allergic to a drug, please note that. If she has Jehovah's Witness, please note that. So, third part, they check you in the patient safety, and the fourth part is applied clinical knowledge. So, remember when we discussed, we said that there is a room, and for example, this is a garage or whatever, you have to put the gate according to this garage, not all the gates in the house you put on this room. So only applied clinical knowledge is just a window or just a smaller part in your this structure case. The core, the wall, the room is your history. If you do your history so perfectly, If you do your investigation, the door is investigation. This is history. This is investigation. The roof is examination. And this window is applied clinical knowledge. If you don't do applied clinical knowledge well, it's fine, they're gonna still pass you. In MRCPI candidate, you are not going on a senior level, they will pass you if you make little bit up and down in your applied clinical knowledge. But trust me, they won't gonna spare you if you don't take history properly. They won't gonna spare you if you don't know the relevant examination and the important investigation for that case. If I am in the my case, if it's anomalies case you got in the exam and you start asking the irrelevant thing like tumor markers of the patient, because she give you in the history she has for example, she has the cyst in childhood or her mother has this cancer, and you are start asking the tumor marker in an anomalous case, it will give a very very negative impact plus unnecessary investigation. You have to justify otherwise. Like if you are asking renal function test, please justify why you need. Examiner won't mind. So starting, there was little bit confusion. Some patients say some students were saying you mind this thing when we did not signpost. Signpost in all the history just for two things. Two things, guys. Number one, pardon me, do you have sexually shared infection? Number two, do you use alcohol or recreational drugs for fun? Alcohol and drugs, recreational. For smoking, no need. So you can say, pardon me, do you smoke alcohol or use recreational drugs in one liner? Usually in a flow, in SPT, I want you guys to use this. But in a long case, it's okay. If you are smoking, then for alcohol and recreational drugs, you can use that. Am I clear? Astra?
Yes, doctor.
And Hira, please just remember whatever mnemonics you want to make for you. Whatever mnemonics. This mnemonics work for me, and I was okay because in my paper I used to write. This was my paper. What I used to do, I used to write here the risk factor, here the name, age, because patient really mind if you forget her name and age. In examination hall, there is no joke about asking, sorry, I forgot your name. No, here, you can forget. Here, if I tell you another name, you can tell me another name. That's fine. But in examination, there is no excuse. Risk factor, her biodata, and here I used to like OG, MSF, SADS, and MB. Like I used to, oh my god, MSF was SADS and MB. Whatever mnemonics works for you, just you don't, there's no need to skip anything. Guys, just give me a second. Just give me a second. My driver's. Nora? Nora? Driver? He's waiting. Okay, so whatever mnemonics work for you, make your own mnemonics, but don't skip a single thing. In obstetrical history, like today, you guys have antenatal cases. In obstetrical history, you have to ask similar pregnancy issues before. Small for gestational age, for example, if she has oligohydramnios, ask about that. Gynecological history, ask about the menstrual period, contraception, and STI. But after the sign, posting, and smear, here don't shorten the history. You have to ask smear in the long case. You have to ask the detail of LMP in the long case, but relevant. Don't forget. Just say this line: "Are you updated with your smear?" That's it. Medical history, for which you visit your GP, whatever the line come, but ask medical history, ask her surgeries, anatomy, ask about the family history, and then SADS mnemonics is for social. How is like her profession, what she's working, then she's allergic to the food and drug. Then D for drug abuse. So here, smoking, alcohol, illicit drug, and S for support at home. M for mental conditions, like how she has been doing and feeling, blood group and reservation, and BMI. Whatever mnemonics is suitable for you, do that. Don't skip anything. Don't skip anything. This page works for you if you make this type of page any case today. I give you any case. If you are not prepared, trust me, you at least you will score 99% in your history. So starting, it's not OG, starting is like HOPC. You know that. First of all, you ask the detail of presenting complaint, like if she has been pregnant, how is pregnancy, current pregnancy so far, and what are the complaints, ask about that. Then this is the systemic history. So are you ready? Who was having the STA, guys? Let's do in a sequence. Hira?
Doctor, please, can you take my case because my
Yeah.
baby.
Sorry. Asra. Yes, LGA. Asra. Asra, it can be
LGA.
any case. It can be any case, okay?
Okay.
Your time starting now.
Hello, I'm Doctor. Hello, I'm Astin. Here is my exam sticker.
Asra, you want to do a long case or structured discussion?
It's up to you. I don't mind whatever you want.
Because poly I kept for structured discussion. Long case is oligo. Long case is reduced fetal moment and the SGA. But okay, we will do that. Let's start. I'll make a scenario. You have Gravida 2, Para 1 at 34 week with ultrasound finding. Deep vertical pool is 10 centimeter. Okay.
Yes.
Now start.
Hello, I am Dr. Asra. I have read one of the exam candidate. I have read the instruction and I am ready for the structure discussion. As my patient is Gravida 2 Para 1 plus 0, she is 34 week pregnant and with the amniotic fluid index of 30 centimeter. Uh, I would like to ask I would like to inquire after introducing myself and the role to the patient. I would like to ask about her name, age, and parity which is already given. Then I would like to ask whether how is her pregnancy so far. Did she remember her last menstrual period, whether it corresponds to date, whether her fetal movements are fine. I would like to ask that if there is any symptoms bothering her, that is any shortness of breath, any pain, bleeding, or any leaking, and whether she has booked herself regularly in the antenatal care follow-up has been done or not. Booking scans and date has been done or not. Blood test has been done. Her blood pressure has been checked regularly. I will review her anomaly scan to rule out any gross abnormality. Further, I will also check her. Ruled out her oral glucose tolerance test to ruled out any the presence of any diabetes. Then I would like to review her serial growth scan from 28 weeks to know the estimated fetal weight and abdominal circumference by fetal biometry, live presentation and amount of liquor which is already given. Then I would like to ask her previous pregnancy. Is it his first pregnancy, or if there's a previous pregnancy, then any history of similar complaints, any history of diabetes, what was the weight of the baby, what was the mode of delivery, any complication, antenatal, intrapartum, or postpartum. I would like to ask her in the smear up to date, any history of medical condition she is going on, visiting her with GP, any allergy to medication or food, any history of surgery of tummy or down below, any blood group and blood preservations. I would like to ask her social habits and social support, and her feeling of low mood for the past 4 weeks. And I would also like to ask her regarding her BMI. And after that, I will do her examination, the relevant examination. I would like to do her BMI vitals and her PLR, and the practical examination for simply journal height, amount of liquor, estimated fetal weight, and lower limbs for any swellings of the legs. And further, I would review her investigations.
Perfect.
Uh,
What is your diagnosis given scenario?
um, in the after reviewing her investigation, after ruling out her ultrasound for any gross abnormality, if it is not, or oral glucose tolerance is normal, then my diagnosis is pregnancy with polyhydramnios, which is in her case 25 to 30 centimeter. It lies in um, mild polyhydramnios.
It's mild.
uh, After 25 centimeter, it is 25 to 30, it is mild. From 30 to 35, it is moderate. And from 35 centimeter, it is severe.
Okay. So tell me, what are the causes of polyhydramnios?
Now the causes of polyhydramnios, usually the two main causes, that is, the first is the diabetes, which may lead to osmotic diuresis, and there is a polyhydramnios if it is uncontrolled diabetes. Or the other condition is the fetal congenital anomalies, in which the patient may present as a polyhydramnios, or sometimes in the twin pregnancy. There is also a polyhydramnios when there is a complication in, like, the twin transmission syndrome.
Okay. Focused clinical history you already told, and relevant examination is discussed by you. What relevant investigation you will ask for this patient?
Um, in this patient, I would like to ask the oral glucose tolerance test to rule out the diabetes, and an anomaly scan for any gross fetal anomalies, uh, and a recent obstetrical scan, for fetal biometry, amount of liquor, and estimated fetal weight and placenta localization, and lie and presentation.
Anything else?
A viral serology, if there is any fever, flu, illness throughout the pregnancy, then I would also like to review the viral serology to rule out the causes of congenital anomaly in baby.
Okay. What is her ultrasound reveals the amniotic fluid index is 30 centimeter, and at 34 week her estimated fetal weight is 4.5 kg.
Okay.
And
Now,
OGTT is normal. OGTT is normal. How you will manage this patient?
okay, OGTT is normal, and her estimated weight is 4.5 kg. Then I will further review her BMI, whether to rule out the cause, whether her BMI is increased or not. If it is, then it may be due to the maternal obesity. The baby is having the large for gestational age baby. At 34 weeks, further reviewing the baby, as her oral glucose tolerance test is normal, and reviewing of the mother. I will further plan her delivery, discussing the patient regarding the implications of large for gestational age baby, and discuss the mode of delivery with her. That is there if that is for the baby. There may be the chance, as the baby is 4.5 kg. There is chances of difficult delivery, that is the shoulder dystocia, injury to the a fracture or injury to the baby, or there may be a sudden death of the baby, or an ICU admission as well. For the mother, there may be a risk of there may be the risk of a difficult delivery, prolonged labor, induction of labor, or there may be a damage to the perineum, or induction of labor, or increased chance of cesarean section or the postpartum hemorrhage. Keeping in mind all these things, I will plan her delivery at follow up a 2 weekly ultrasound, and as she is of the 4.5 kg, I will plan her cesarean section at 37 to 38 week, as the her liker is increasing, and her weight of the baby is 4.5 kg, more than 4.5 kg up to 2 weeks. So I will plan, being a safe obstetrician, I will plan giving her telling her about the pros and cons of elective cesarean section and the spontaneous vaginal delivery, as there is a high chances of perineal trauma or shoulder dystocia in the baby. So for better for her is for the elective cesarean section. Uh,
How you will
uh,
do surveillance now onward? She is at 34 week. What you will do now?
for the 34 week, I will keep her on 2 weekly. I will review her scan after 2 weeks. And as her oral glucose tolerance test is normal and all the things are normal, I will ask her whether she is having, if anything is affecting her quality of life, or as there is any discomfort. There is an option of amniocentesis or some drugs, but she is on 34 weeks, so we will not give the answer to reduce her liker. There is another option of the amniocentesis, which we can also discuss with the patient as well.
What are the
If
indications for amniocentesis?
um, if the patient is having symptoms of discomfort, or yeah, discomfort, or it is a severe polyhydramnios, then we may have a option of amniocentesis.
Okay. What are the precautions for that?
It should be done in the tertiary care hospital. There is it will be the she should be provided with the painkiller prior to that, and ultrasound should be available, and she should be tell about there may be a chances of a risk of bleeding, or there may be a chance of port prolapse, or so. She should be aware all the pros and cons of this, and after that we will clean. Doctor, I don't know the procedure of
You are
amniocentesis
doing
properly.
perfect. You are doing perfect.
Uh, okay, we will. My senior will clean and start with the.
Thank you,
Um,
thank you. Time up. Time up. Actually, you answered all my question. Now I was asking additional question. Perfect, mashallah. This was so beautiful. I couldn't find any mistake to tell you. No mistake
Thank you
at
so
all.
much.
No mistake
I
at all.
have to review the process of amniocentesis, that I forgot time shortage. My baby is irritating
It's
me.
okay. It's okay. It's okay. It's okay. Because you were prepared for LGA, so I made poly and LGA mix. Just because, like in exam, they give us a cooked mixture, not a single thing. So it was so beautiful. Mashallah, keep it up. Just little bit when you I asked you what is the diagnosis. So the it's from 24 to 29.9 or 29.5 is mild. From 30 and 34.5, I guess it's moderate. So 30 is comes in moderate category. But it's okay. It's absolutely fine. If you have read in the 30, that was fine. In my key, it was moderate, but it is mild as well. When you start your case, you say, as Gravda 2, para 1, 34 week, with amniotic fluid index is 30 centimeter and deep vertical pocket is this. My probable diagnosis is polyhydramnios, mild grade or moderate grade, whichever comes in. Start like this. Okay? How you will approach your patient? Start like this. You give a
Okay.
beautiful history. Nothing was missed. Perfect. Right now, you ask about her fetal movements, how she is coping, her presenting complaints right now, shortness of breath, any hemorrhoids, any difficulty in her bowel, bladder, patient symptoms. And then baby symptoms. Baby is moving or not. Then risk. You told maternal and fetal risk. That was beautiful. Don't say the tertiary care. Instead, you will replace this with consultant led unit and involvement of fetal medicine unit. This was the safety point. When I asked about the amniocentesis, you won't do amniocentesis. Fetal medicine unit will do amniocentesis for her. Okay. And right now, I asked you what is you will plan. She is at 34 week. How you will do the surveillance? So from now onward, 2 weekly growth scan. Since she is already 34 week, at 36 week, you will make an MDT, then decision of the delivery, and recommended is cesarean section for her, which you already done beautifully. Do a CTG right now at 34 week. At least check the status of the baby if he is doing fine or not. The grade, you can do little bit up and down. It's absolutely fine, but start like this. My patient is having polyhydramnios, this grade. I will start doing this. Then you go for your history. In the causes, like when I ask causes, try to divide the fetal cause, maternal, placental, and idiopathic. It will give a very nice impression. And just add one line according to guideline, according to the TOG article. Okay?
Okay.
You covered mostly, but it will be very beautiful if you do like focus history was perfect. Nothing was left. I loved when you asked about the detailed anomaly scan because here you can rule the duodenal atresia, GI obstruction, neuromuscular. You have asked her the fetal movement, then structural anomalies, chromosomal abnormalities, how the scans has been done so far, and another thing is a single pregnancy or twin pregnancy. You have to ask in the history because I didn't give any additional detail. You have to ask. And it's a sudden increase her tummy size or it's gradual? Because in the the TTS there's a sudden increase. You touch viral serology, TARS, B19, all causes were covered. Just make them in compartments. That will be easy for you. Rest things were perfect. Two things, NSAIDs and ACE inhibitors. They are the causes in the drugs. If examiner asks you. And if you have to ask in SPT, if you ask from your patient, you have to ask her, are you using any painkillers, NSAIDs, or blood pressure medicine called ACE inhibitors? Examination, you did it very well. Abdomen patient, her own assessment is her CVS, her respiratory symptoms, her tummy size, varicosities, and edema. These 4 5 parts are for mom. Rest do for baby. And mention that because of the difficulty in palpation of the fetal part, I will rely on the ultrasound to check the fetal size. And you will check the fetal heart rate, and there will be difficulty. Then you have to do the Doppler, fetal heart Doppler. Then investigation. You already mentioned this was the beautiful point. Fetal medicine unit, you will refer. They will do the detailed anatomical survey again, even at it is the 34 week. They will do it again because it was done at 20 week. They might not pick at that time. There might be some abnormality. So you have to confirm it again. OGTT, I gave you normal. If I didn't give, then you ask for OGTT. Viral serology and you asked this, Asra? NTD status.
I have asked about the blood group.
Blood group. Okay. So when you do an investigation, here you come again with blood group and the antibody status, because sometime if hydrops come in a severe grade, it can cause the poly as well. So immune hydrops and non-immune hydrops you have to take in count. Then twin pregnancy, if it's not given, then there is no need. So diagnosis, you have how you tell there are the two spectrum. Either it is mild idiopathic, nothing to worry, routine antenatal care. If it is moderate with symptomatology, and if it is severe alone without symptom, severe usually cause symptom. But if the grade is like more than 35, and if it's moderate with the symptomatology, these two are the worrisome, and we have to involve CLU and fetal medicine unit. Management, you did it nice. Usually mild, nothing to worry. OPD monitor, do the surveillance 2 weekly and do the intermittent heart auscultation, like fetal heart rate auscultation, or tell her about the movement, because of the poly babies moving all around, so patient usually don't feel the movement. It's a passive movement more, so you have to ask about the fetal movement, any change in the fetal movement. Then moderate to severe, here even it can deliver with the midwife. It can deliver. There is no need. From moderate to severe onward, you involve the fetal medicine unit and consultant-led care. Or if with the mild any symptom, then realize the severity and top up that grade. Amnio reduction, usually we do for the severe cases. What the patient has, patient can has the breathlessness, inability to do the daily house chores, or the patient is Braxton Hickson started. Patient is having little trouble in her movement. So that we think the amniotic drainage, or even the large fluid is compressing the baby or stretching out her tummy, her urine output decrease. We will do the amnio reduction. The drug is indomethacin. Now that is not recommended for these cases, even at 34 week. I loved it. You said there is no rule of that. And you will, if we had to done, you will do amnio reduction. Otherwise, perform the cesarean. If it was only Asra, it was only mild polyhydramnios, or if it was the polyhydramnios, but fetal weight was not large for gestation, it was not 4.5 kg, maybe it is 2.2, 3.4, then we won't go for the cesarean. You remember, we will do the planned induction. And for these cases, cord prolapse, highlight so much, so much, so much. You have to highlight the cord prolapse. That's the safety point. I made the large for gestational age. You went for the shoulder dystocia and the tears and all that complication. Beautiful. Must remember cord prolapse and tell it very highlighted. Cord prolapse. We do their planned induction is usually done in the theaters, and the senior do their ARM if we has to do. Like that's called the stabilization induction. You know this term, right?
Yes, doctor.
But our patient was like, obviously, she is 4.5 kg at 34 weeks. She will end up in 5 kg at 38 week or 37 week. For our patient, there was no role of stabilization induction, but examiner can ask that. Intrapartum cord prolapse prevention. You have to make a stand by your team. Even you are doing the cesarean, please remember there will be shoulder dystocia in the cesarean as well. There will be the massive PPH to the mom for polyhydramnios plus LGA. If it is mixed, massive PPH. These are the safety points. Neonatal, what for LGA, what is the most important neonatal risk? Like after shoulder dystocia, if it is born, postpartum, what is the most important risk? Hypoglycemia. They can have the transient tachypnea, respiratory problem. You have to rule out all the anatomical survey again with the pediatric. They will check the patency of their anal sphincters, their all the sphincters, they are taking the feed or not. They will keep them in NICU. They will do the observation, tell. But hypoglycemia, please highlight. Then for the mom, prevention of the PPH, VTE, and the contraception. Most important cause is diabetes. When to ask amnio reduction, we already discussed. If it is idiopathic, no complication, baby is normal size, we take them to 39 week, 40 weeks, like they let them deliver there spontaneously. Just tell them the risk of cord prolapse if it is mild. Then fetal causes and biggest intrapartum risk is cord prolapse. This is their key, examiner's key. Now, well done, Astra. Very beautiful. I really loved the case. Very perfect. No
Thank you.
deficiencies, nothing, mashallah. I hope this rhythm and this flow you will continue in your exam. Hira or Monia? Monia, I guess she is on duty. She is just listening us.
Yes, ma'am. Sorry, ma'am. My duty.
Okay, so okay.
Yes.
Don't say sorry. Because last time I only heard you a lot. This time,
So
let your colleague.
compensated. No? But
Yeah,
I love to
compensate.
present. But anytime patient can enter, so I have to stop in between. That's why, ma'am. So I'm listening only.
It's okay. Hira, are you up, dear? Hira has the SGA or IUGR, I guess. Hira?
Yes, I'm up.
Oh, okay.
How are
Hira,
you?
You heard the one page summary I showed in the beginning?
Yeah.
Okay. Today I am marking you in history as well, and I will be marking you in timing. These two are your examination criteria today. Okay. You
Yeah.
enter in your cubicle and start your case. This is your scenario given. And this is ultrasound finding. I'm starting timing because you are reading.
Yeah. Okay. Hi, my name is Dr. Hira, and this is my exam sticker.
Continue with your case, doctor.
Hello, I'm Dr. Hira. I will be your doctor taking care of you today. Can I know your name and age, please?
My name is Linda, and I am 25 here. 28 here.
Okay, thank you. Is it okay if I call you Linda?
Yeah, that's fine, doctor.
Okay, Linda. Linda, I'm going to ask you a few questions about your current pregnancy and a few medical and surgical questions. I have very short notes and your ultrasound finding as well with me, which shows that you are 35 weeks and 2 days pregnant. Is that correct?
Yes, doctor.
And this is your second pregnancy?
Yes, doctor.
Okay. And you have one live baby, right?
Yes, doctor.
Okay, great. So if you have any questions in between, you can stop and ask me, okay?
Okay, doctor.
All right. So we'll be asking a few questions and I'll do your examination. We'll go through a few investigations and then we'll discuss what to do from there, okay?
Okay.
Okay. So as we know that you are 35 weeks and 2 days pregnant, is there any current complaint that you have?
No, doctor. I'm doing great.
Okay. Um, so you did your ultrasound. Can I confirm? I'll just confirm the name and date on the ultrasound. It's Linda. You are 28 years. Okay. So it shows that the baby is a little bit smaller, but everything else seems normal. So you said this current pregnancy is fine, right?
Yes, doctor. Doctor, you said baby
How
is
is the
smaller.
movement?
Baby is small size.
Yes, it's a little bit on the smaller size
Okay.
at this at this time during the pregnancy. And that's what I'm going to ask the questions around. So, how is the movement of your baby?
Doctor, movement is very good.
Okay, great. And has there been any pain or bleeding or fluid leak from the vagina?
No, doctor.
Okay, that's great. And during this pregnancy, any infection, fever that you had?
No, doctor.
Okay. Uh, any history of blood transfusion during this pregnancy?
No, doctor.
All right. And uh, your pregnancy, what was your last menstrual period date?
Doctor, I'm 35 week. By
Okay,
dates, I don't remember exact.
okay. And it was a planned pregnancy?
Yes, doctor.
Okay. Um, and eh, how was your previous pregnancy?
Doctor, I have a baby boy before, and
Mm-hmm.
I delivered with the cesarean section.
And do you know
And
the reason for cesarean?
yeah, doctor, I remember the doctor said me at that time the baby size was smaller. So when the baby was born, it was just 4 pounds.
Okay. And did they tell you the reason?
No, doctor, they didn't told me any reason for that. I'm still
And
worried.
okay. Were there any complications during that pregnancy, like in your previous pregnancy?
Doctor, my blood pressure was little bit raised, and that
Mm-hmm.
pregnancy gave me a medicine for that. And then they said like you check in the next pregnancy. So you see, I'm a 35 week. They have been checking my
Mm-hmm.
blood pressure regularly, but it is normal now.
Okay. And you're not taking any medication
No,
additional,
doctor.
right?
No,
Okay.
no.
Okay. Did they start aspirin for you in this pregnancy?
Uh, yes, doctor.
Mm-hmm. And are you taking that regularly?
Yes, doctor.
Okay, good. And otherwise, and the baby is doing fine now?
Yes, doctor. He's
Okay.
perfect.
Okay. And has anyone told you that you were a little bit on the smaller side of the height?
Yes, doctor. Actually, me and my husband, we both are a little bit thin, lean, and smaller. It's
Okay.
our genetic, like our height is little reduced.
Okay. Okay. Um, and your dietary habits are perfect. You're eating
Yes,
everything, no
doctor.
restrictions. Okay.
No, I try
And
to eat.
okay, that's good. And you're taking multivitamins as well?
Yes, doctor.
Okay. Is there any medical or surgical history? Is there any, sorry, is there any medical conditions in the past other than you mentioned the hypertension or high blood pressure in the previous pregnancy?
No, doctor. I have asthma as well, but I am on inhalers for that, and it is controlled.
Okay, great. Any surgeries on tummy or down below?
No, doctor. Just cesarean. I told you.
Yeah. Okay. And how is everything at home?
It's fine.
Okay. You have good support, you have good help with you
Yes, doctor.
at
It's
home? Okay.
perfect.
Okay, great. And is there any family history of like having small babies? I think you mentioned recently that it's your family.
Yes, doctor.
Okay. Um, what do you do for a living, Linda?
I'm a banker, doctor.
You are a banker. Okay. Any recent stressors at work at all or
Sorry,
during this
doctor. Come again.
any recent stressors at work or during this pregnancy?
No, doctor. We're doing great.
Okay, great. Any allergies to any medications that you take other than your inhaler and the aspirin?
Doctor, in the beginning, I used to take that tablet called the steroid tablet. I took that for 10 weeks. Then my asthma worsened in the start. Then I am on inhaler. So that's prednisolone I took for 10 week only.
Okay.
And right now I'm on aspirin and my tonics.
Okay. Thank you for telling me that. Any allergies to medication?
Come again, doctor?
Do you have any allergies to any medications?
No, doctor.
Okay. Pardon me for asking this. Do you drink alcohol or smoke cigarettes?
Doctor, I am a smoker and I smoke in this pregnancy. Sorry, I tried my best, but I couldn't skip.
That's okay. How much do you smoke?
Doctor, 9 cigarettes sometime, but on often 6.
Okay. You said you have tried, but you were not able to quit. Is
Yeah.
there something that you would be interested for us to help you, my colleagues, if you're
Yes,
interested?
doctor, it will be helpful.
Okay, then I'll connect you with them at the end of this consultation, and we'll take it from there.
Okay, doctor.
Okay, great. And also, pardon me for asking this, any recreational drugs?
No, doctor. Never.
Okay. So what's your blood group, Linda?
Doctor is B positive.
Okay. And you told me that your height is on the lower side. You know your BMI by any chance? It's the height to weight ratio?
It's 19.
Okay. And during this pregnancy, I know it could be like overwhelming to work, having a baby, and then getting pregnant. I know that you have good support, but how has your mood been lately?
It's good, doctor.
Okay, great. Okay, Linda, thank you for answering all of my questions. I would now want to examine you, but before that, is there anything that I may have missed in your in asking you questions?
No, doctor.
Okay, great. So I would want to do the examination in the presence of a chaperone. Is that okay?
Yes, doctor.
Okay. So I am going to
Okay, tell me what relevant examination you will perform on your patient.
Okay, so in the presence of chaperone and after the hand sanitization technique, I would have taken the verbal consent already. I would want my patient to be exposed from the sternum below, till mid-thigh. I want to examine her. Focused examination would be the abdominal obstetrical examination. I would want to look at the general contour of the abdomen and also the symphysis-fundal height. As it's a smaller baby. I would go for the fetal heart sounds. I would look at the lie. And as she is 35+2, I would also do the fetal lie and the presenting part. Yeah. And then she doesn't have any complaints of perivaginal leaking or bleeding, so I wouldn't do the vaginal examination.
Okay. Now, please
I
summarize
would
your case.
also
Yes,
I would
yes.
also
Please.
look at a general physical for pallor as she's on the lower side of the weight, and also do the formal height and weight check for her.
Perfect.
My patient is Linda, 28 years old. She's routed to Paragon at 35+2 weeks. Have a BMI of 19. She's a banker by profession. Known case of asthma and previous known case of asthma presented with small for gestational age baby on the ultrasound. Less than the 10th percentile. Other parameters are normal. Her risk factors for small baby are the constitution, as she's smaller herself and she has a family history as well. Previous small for gestational age baby and pregnancy-induced hypertension in the past. However, she is taking a preventive medication aspirin in this pregnancy, and her blood pressure has been normal. Her fetal movements are normal as well. There is no complaint of leaking perivaginum or any present fetal or maternal complaints. Her asthma has been controlled. She's B positive. And on examination, examination is unremarkable.
Okay, you want examination finding? Her blood pressure is 118/76.
Mhm.
There's no edema in her body. Her appearance is well. BMI is reconfirmed as 19. And symphysiofundal height is less than 3 centimeter than 35. So it is 31 or 32. 32.
Okay.
There is a singleton pregnancy, and the presenting part seems cephalic. Fetal heart rates are normal.
This seems to be a reassuring exam, as the Leica volume is normal and the Doppler is normal as well. Like I said, she has a few risk factors for small for gestational isolated SGA baby, which is like constitutional, previous SGA, and an element of a
Okay.
lower BMI as well.
Okay. So
I
how
would
you will
want to,
proceed from now onward?
yeah. As her Doppler is normal, we would do a weekly biophysical profile
Any
and
investigations you want from me? Investigation.
um, investigations. We can do she's B positive.
Hmm.
Um,
You can
I mean,
ask
just
general health profile here.
yeah, it's we can do a complete blood picture, like full blood count, looking at the hemoglobin, the platelet count, and also the WBCs, just to be sure there's no infection.
Your hemoglobin is 11 gram per deciliter and platelets are normal.
Okay, urine dip as well.
There is no proteinuria.
Mhm. Okay. Um, what else? I don't know what to ask for, like the
Okay,
investigation.
okay,
Not
doctor,
much
proceed.
needed. So she's at
When you go
35
to the
plus.
listen, when you go to the management, we won't come back to the investigation. Okay. She's grabbed a 2 para 1 at 35 week. From now onward, you will deliver her. You will do all the management postpartum. No coming back to the investigation, right? So start.
You want me to admit her? No, she's not being admitted, right? So we can do
Yeah.
later as
Okay,
well,
fine.
right? Yeah. So so what do I do now? I tell you the
Yes, manage your patient, doctor.
okay. So as she is 35 plus 2 weeks, and she is less than the 10th percentile with normal Doppler and AFI, like her volume is normal, we will do the biometric Doppler every 2 weeks until 30. I mean, my plan is to deliver between 37 to 39 weeks. And during that time, we will do fetal biometry and the Dopplers every 2 weeks, keeping an eye on the fetal movements. We will guide the patient to let us know if there is any recent leaking, reduced fetal movements, or there is any bleeding or pain. After 37 weeks, just done right away. And yeah, we will
Tell her,
also.
Hira, listen. At 35 week, tell her first the risk factor for mom, for baby.
Oh, okay,
Do
yeah,
the
yeah.
listen,
So
then do the surveillance, then plan the delivery, how you will delivery, mode of delivery, then postpartum. Okay. So start.
okay. So Linda, as you have answered my
No, don't talk
question,
to Linda. It's a long case. Talk to me.
okay. So I will tell my patient that based on her history and ultrasound report and the findings I have on from examination, it's a diagnosed case of small for gestational age, isolated, um, due to the risk factors in her history as constitutional or genetic component, a previous SGA baby, and could be the use of steroids as well in the beginning of the pregnancy. So I will tell her that when we will deliver the baby, which would be between after 37, but no later than 39, I will ask her to keep an eye on the movements of the baby. If there is any change, if she feels their movements have been reduced, report right away. I will also tell her the measures what to do, like left lateral hydrate herself, and also at the same time reporting to us. I will also tell her that we will do 2 weekly ultrasound scans in which we will see the biophysical profile of the baby and also like the fluid around the baby as well as the doing the Doppler for the blood flow to the baby. If there are any changes, I'll involve my seniors and we will plan delivery. But our aim would be to deliver her before 39 weeks. And I will tell her that the mode of delivery, if everything is okay and there is no other indication for operative delivery or cesarean, then we would proceed with induction of labor. Like I said, between 37 and 39 weeks, if the Doppler and the Leica and the biometry is normal. At any point, if anything changes or she goes into labor on her own, obviously we will ask her to see us in the obstetric unit. I will involve my seniors at that point, and we will. But if nothing happens, then we'll go for induction of labor. We will admit her. We will induce her. And in
How
the
you will
during
induce her? How you will induce?
with prostaglandins, we will give her the option of medical and mechanical methods, and we will tell her the success rate as well. We will tell her how long it could take, and we will also tell her about the field induction of labor. Um, and yeah. And then
Continue.
during labor, obviously we'll do the CTG monitoring as well throughout the process of labor. If anything changes on the CTG, obviously we'll involve our seniors, we'll expedite our management, and we'll tell her what to expect in the latent phase and the active phase. And postpartum, once she delivers, we would tell her about for the baby and for the mother. So let's go for the mother first. Postpartum, we'll ask about the mental health, of course, as taking care of like in the immediate postpartum period, we will manage for like any like excessive bleeding, like PPH, mood changes, and we'll tell her to stop the aspirin as well. We'll tell her to continue usual tonics. We will tell her to come at 6 weeks to discuss for contraception and what to do for the next pregnancy. As she has already two small for gestation age babies, she would have to keep a strict eye on the blood pressure from starting of the pregnancy if she becomes pregnant again. Use of aspirin would be a must from like second trimester, for somewhere from 12 to 14 weeks, starting before 16 weeks. And also keeping her nutrition up to date and all of that. She
Okay.
was smoking as well,
You
so I would connect her with the smoking cessation team as she wants to quit smoking.
and
And
you induced your patient, and
yeah,
after like when she was 4 centimeter, the gush of the blood came out of the vagina, and the fetal heart rates are dropping. What has happened? What is your diagnosis? Well, how you will manage?
the fetal heart rate dropping. I will see if there is what was the location of the placenta? Is there a cord prolapse as well? I'll see, like, I'll do the vaginal examination. Is there a cord prolapse or we'll do continuous CTG as well. I'll involve my seniors. What is my diagnosis, you asked?
Yes, tell me your diagnosis. Placenta was anterior when you induced. You checked everything.
Okay.
Heart rate is
Kasha,
80.
is it cord prolapse?
Blood comes in cord prolapse.
No. Was it previous? So it could be abruption.
Hera, you induced a VBAC.
Oh my God. Yes, she had a cesarean delivery. I completely forgot that.
And
Oh,
even she is asthmatic and you induced her with prostaglandins.
oh
Ta-da.
no.
Ta-da-da-da.
इतना सारी चीजें you, Dr. Saba, you make it so difficult. Okay, okay, okay.
You
Sorry,
know,
sorry.
Hera.
I also said mechanical, but I
Yeah,
totally
yeah,
forgot
yes,
asthma. Oh
yes.
no.
It's okay, it's
Okay.
okay. Continue. She's
Um,
doing the bleeding. What is your diagnosis? Manager.
now
Still
this is
have one
rupture.
minute. Yeah, yeah.
This is rupture. So
Okay.
I would call for help. I will involve my seniors.
Mm-hmm.
And I'll stabilize her, and I will stop the center, whatever it was, if we have turned on
Mm-hmm.
any tocolit. I will tocolize as well, and we'll
Mm-hmm.
prepare for cesarean section, urgent life open cesarean section
Perfect, Hira.
or
You
laparoscopy.
ended your case at 25 minutes and 60 seconds. Like it's 59. Okay. Exact 26 minutes. We finished our case. Perfect. What blunder you made, we have a strong tendency to make in the examination. It's very okay, it's very fine. That's why we asked, that's why I was making this listen. I was making this risk factor. I was not joking. I made this page when I was starting her management. I know she has previous SGA, this time continuous CTG. She has asthma, no prostaglandins. Even postpartum, I have to tell no NSAIDs. Asthma was for that purpose. For cesarean section, if she can go low threshold of VBAC, but preparation of cesarean on the back end. Low
Oh my
threshold for
God,
the
I
VBAC.
completely
I will.
missed this.
It's okay. You can induce her. If you do the
Yeah.
cesarean, my next question was your patient wants VBAC. Okay, so the word VBAC was missed. You simply induced her. You did not set the VBAC in consultant led unit with the low threshold of cesarean. Since patient is asthmatic, I would avoid prostaglandins and I will do the mechanical induction. Okay. These two lines give you a gold medal. Otherwise, already your case is passed. Nothing was missed. It was so perfect. I was just have a look of importance of these 4 or 5 risk factor when you do in the
Yeah,
beginning.
yeah.
Just have at the end, just look at them. Even I forgot to write the smoking. You did manage in the smoking as well. And then contraception, preferably large contraception. Everything was perfect. Even you
Yeah.
aspirin, everything is beautiful, mashallah. Just this
Yeah.
blunder which you made, even at my time, I made. My patient had polypectomy. She was asthmatic. I gave her painkillers, but I forgot to say I will do the PCM. I will avoid the NSAID. This line I also like. My examiner, she said me, you did your case perfectly. Just please mention which painkiller you will give. I said the painkiller. No? She asked me at the end because like there was a little frankness and I had a spare time 2 minutes. She asked me, do you want to ask anything? So add anything. So I forgot to tell. It's okay. If it happens with you, it can happen in exam. But our aim is not to happen in exam, inshallah.
Yeah.
Today
Okay.
your history was perfect up to the mark. You set a beautiful introduction, agenda, history of presenting illness was fine. Just ask, does she feel her tummy smaller in the beginning, like in the third trimester, or it's a sudden?
Okay.
Number one, this point, please mention. You completed your HOPC, then you ask, it is my planned pregnancy. Preferably ask in the beginning, okay? Planned pregnancy, congratulations, and then start. Obstetrical history, okay, she has PIH. You already pick aspirin as a risk factor. She was on a smaller side. There was beautiful question about the nutrition. Asthma, she told even later on, she remembered she took an prednisolone. Steroid, even for the short term use, they were also a risk
Yeah.
factor for
Yeah.
SGA. But you already pick up, there's no need. Cesarean done, you asked the indication, and smoking quitting. It was very beautiful when she told, sorry, doctor, I couldn't serve. You said it's okay. You made her feel it's okay. You can still try because smoking has detrimental effect. This is a cause of small for gestational age as well. So history you finish in 10 minutes. Try to shrink it down because make sure your examination should have 3 to 4 minutes. Because if the 12-minute time is crossed, your examination will be left.
Mhm.
So you left 2 minutes only, right? For examination. In 2 minutes, you
Yeah.
are unable to perform because you have to stand, you go to the dummy, or two examiner will stand you and they will ask you to perform the obstetrical maneuver. And sometimes they can ask you, do you do the parvaginal examination? You already said there is no leaking, nothing, and she's not at term. If she has been a 39
Mhm.
week, then you will check the bishop score, na? But right
Yeah.
now you don't do. So only obstetrical examination, fetal heart rate auscultation you have to perform. So 2 minutes is little bit lesser for that.
Yeah.
Okay. Rest everything was beautiful. The pace was, momentum was very soft, very perfect. Examination you did all. Hira, when I asked you what relevant investigation, you start from the general physical examination. I will recheck her BMI and recheck her blood
Yeah.
pressure. Okay,
Yeah.
recheck, because you know it's constitutional small and you have to prove it's constitutional small. You have to recheck BP and BMI, blood pressure. Say blood pressure,
Yeah.
no BP. Then obstetrical examination was perfect. In the history, one thing you missed. You told me Linda 28 Gavra to para 1, banker, BMI 19, known case of asthma, SGA, my proper diagnosis, constitute small, PIH. Yeah, smoking.
Yeah. Smoking
She is
allergy.
a chronic smoker, taking 6 to 9 cigarettes per day. Okay.
Yeah.
This one thing was missing. Diagnosis was beautiful, constitutionally small. In the previous pregnancy, you asked her risk factor. She has the blood pressure. You asked her, do you had any headache, visual changes, or epigastric pain in that pregnancy? Because PIH, when they deliver her, patients say maybe because of blood pressure, baby weighs about 2 kg at term. So inquire about that as well. Okay. In this
Mhm.
pregnancy, even ask her blood pressure is controlled, but maybe suddenly at that time you can pick. So please ask current pregnancy, preeclampsia, PIH symptoms. She was the risk, she has the risk factor. This obstetrical history, and previously you asked for the SGA and birth weight. Another thing, Hira, when she told I am not sure, it's about 35 week. This point you have to write in here, and please ask when you come to investigation, ask dating scan to correlate the date. The
Yeah.
biggest reason for SGA is the wrong dates.
Is wrong
That's
date.
all.
Yeah.
That's all. It can be
Mhm.
wrong dates as well, right?
Mhm.
So here smoking you address, quitting was beautiful. Nutritionally, she has this problem, constitutionally small, no other autoimmune diseases. Medication you inquired, just ask in one liner. Any other medication? She told the prednisolone later, because I was trying to give you another cue for the constitutionally small. I don't want you to make this case for preeclampsia or IUGR. You picked it very well. Otherwise, if you have to ask about the warfarin and beta blocker. They are the certain risk factor. So when you were asking her the current pregnancy, ask her, she has been like so far at 35, she has been told previously that her baby or tummy size is being smaller than beginning.
Mhm.
So here
Yeah.
the importance of placenta localization, or the anti-scan,
Yeah.
or the detailed anatomical survey. That when I was saying you any other investigation, I was expecting you ask the dating scan,
Dating
anatomical
scan. Yeah.
survey, and
Mhm.
you can do the CTG as well, because she is 35 week first time. Her estimated fetal weight, if you ask, I guess I have written here, so that's why you did not ask estimated fetal weight on scan, right?
Yeah.
So
Mhm.
okay, try to do a one time CTG, because you have
Okay.
to make sure you are sending her home from today. You are sending her home and tell her the red flag sign.
Yeah.
Even she don't have PAH, she had the history, but tell her the red flag signs, any blood RFV and headaches or whatever. Okay, and the fetal decrease of fetal movement. Small
Yeah.
fetus mnemonics I used at my time. You can use this, like smoking, substance abuse, maternal diabetes, hypertension, autoimmunes, placenta localization, low BMI. Your patient has this one, right? In the fetal, ask fetal anomalies, exposure of drugs, if she has the single pregnancy or twin. I gave you single, but it can be twin as well. We will do the
Can
twin.
be.
We will do the twin as well. So any uterine problems? Did you ask gynecological history?
I just
As
asked LMP.
yeah, STI was missing.
I asked any infections that you had during this
No,
pregnancy.
that
The
infection.
STI I didn't ask.
Yeah, Hira, that infection can be like torch, or that was a
Yeah, yeah,
critical
yeah.
question.
I
That was
asked
a
her.
relevant question. Just make
Yeah.
sure the gynecological history should be complete. So examiner should not have any point to like take your marks. Your
Mhm.
case was very beautiful, very perfect. Examination you did up to the mark. Investigation CTG and ask about the dating scan to correlate with the date because my patient is not sure of the date, and detailed anatomical survey if it's available now. Then they can ask you in the management if you had time. They love to ask how it is not fetal growth restriction. So please read this comparison. They have the problem with their placenta, with their Doppler, and the Liker volume is usually low and the CTG is usually abnormal. Here the CTG is beautiful, so you take them to the term. Management. So when I ask the put a question, how you manage your patient. So here you will say my Linda Gravda 2 para 1. My patient is at 35 weeks. She has constitutionally small. So I would tell her the maternal and my aim is to deliver a healthy outcome to minimize the maternal and fetal outcome. Maternal risk are this. Fetal risk are this. Okay. Mom has the like failure of induction, strong risk factor again for the cesarean. She can have the frequent hospital visit. She can have the recurrence of her blood pressure for the mom and for the baby. Even IUFT is the strong risk factor for the SGA, right? SGA can lead to IUFT. So that was the red flag sign, fetal movement and surveillance. So I will, from now onward, I will do the 2 weekly ultrasound. I will book her consultant-led unit and then do all this, take care of fetal movement, outpatient monitoring. Here, I did not set any fever or flu, so you don't need to ask touch profile. Otherwise, if I told you in the beginning, you can ask in investigation. Your delivery was perfect. Time of delivery, you already know. If you do the cesarean, that's perfect. Just avoid, she's on aspirins. Oh, sorry, she's asthmatic. Avoid the NSAID and do all the like management. Even avoid the copper T in the asthmatic patient. So when you deliver cesarean, examiner will ask how the patient wants to deliver vaginally. So just remember what is the VBAC, low threshold for the cesarean, and continue CTG and consultant-led unit, right? Are you with me, Hira?
Yeah.
Okay. So this was finally done. Perfect. Mashallah. Who is for oligohydramnios? Hira, you want to take oligo? It's a long case again. Asra, Monia, anyone?
We can do it. I mean, if we have to do it, there's no one else.
Yeah, it's a similar like your previous case. It's similar. I preferably want another
So do you want
candidate.
to do like reduce fetal movements then, and make
You
this?
want to do that?
I mean, yeah.
Okay,
No,
go for reduce fetal moment. Yes.
that's a long case too.
No, that's not long case. So preferably let's do that. So you will have a little bit mind break.
Yeah.
Then if no one can come, then we will come back to this oligo. Okay, come. This is a structured discussion. Okay, it's a circuit. You'll be having 10 minutes and
Okay.
make the diagnosis, and then we will do the detail of it. I will ask question and you have to answer me. Okay. Let me start timing. Start. Enter.
Hi, I'm Dr. Hira, and this is my exam sticker.
Read your case, doctor. Hira, this block is for me. It's not for you, okay? The upper block is for you only.
Okay. Okay, I'm ready. So I will start my case by asking the demographic information like the name, age, confirming the parity, and also the gestational age according to her last menstrual period date. Then I'll ask about dig more about the complaint that she had that about the fetal movements. I will ask her like how many fetal movements has she perceived during the last night, and is it the first time that she perceived reduced fetal movements, or has it been before as well? If before, what was done? Was there any diagnosis given? Um, uh, and um, is she undergoing any additional like continuing 2 weekly or 3 weekly surveillance via Doppler or like ultrasound, frequent ultrasound examinations if she has previously had reduced fetal movements as well. Then I would ask her the any episodes of abdominal pain or any tightening in the abdomen, any bleeding from vagina, or any fluid any fluid leak from the vagina as well. Any recent illness that she had uh, just around this time. And I would also ask about her previous obstetrical history as it's significant for the intrauterine fetal demise at 37 weeks. I would ask, I would confirm her the cause, and as my exam sticker says that it was because of the placental insufficiency. I would ask if there is any history of high blood pressure during this pregnancy or previous pregnancy, any history of diabetes. I would also inquire about her BMI. I would ask if she's taking any medication, um, any allergies to medications, any surgeries, and tell me down below. I would ask her blood group. I would inquire about negative or RH antibodies to rule out any fetal maternal hemorrhage episode. And I would also want to ask if she has any disorders related to blood, like thick blood or clotting, to rule out thrombophilia. Um, for the previous, I would ask what was the mode of delivery. Not the mode of delivery, uh, uh, what was the cause and the mode of delivery, yeah, and how was it managed? And did she have reduced fetal movements in that pregnancy as well? And then
How you will approach clinically to your patient, relevant examination, clinical approach.
so clinically, I would want to start off with the general physical examination. Um, I would do a BMI check as well. I would want to do an obstetrical examination. I would want to expose, in the presence of a chaperone, I would want to expose her from xiphousternum to mid-thigh. I would look at the symphysiofundal height. I would do fetal health with the handheld Doppler or Pinard, and I would do a CTG as she is 39 plus 1 weeks. I would want to make a decision. I would want to do a bedside ultrasound as well for the movements and the biophysical profile. I would want to get her dating ultrasound and detailed anatomical ultrasound. If it has not been done, then we would get it done. And if there is any positive finding, like if the CTG is abnormal or I couldn't hear fetal heart sounds normally, or if there is any changes like less liker or biophysical is less, then I would want a departmental scan to be done within a day. And I would want to admit this patient if any of this becomes abnormal.
Okay. What are the causes of reduced fetal movements?
The causes of the reduced fetal movements can vary. ranging from like the maternal perception to like the placental causes to infection uh, to large volumes of liquor
Mm-hmm.
um, to like the placental causes, like I said, could be due to the hypertension or diabetes. And what else? Um, a very small or very large baby.
Okay. So your patient is at 39 week. How you will manage this patient? What you will do? You have done with your history and examination,
Yeah.
and there on
So is there any positive finding on examination?
there is no positive finding on examination. Fetal heart rates are positive, and she has the diet control, gestational diabetes mellitus, blood sugar levels are normal.
Okay. I would want to admit this patient, and as she is 39 plus 1 week, I would want to deliver her. As she has a previous history of intrauterine fetal demise at 37 weeks. I would want to counsel my patient for admission and also possible delivery. I would involve my, not possible for delivery, I would involve my senior consultant as well, as she's high risk for intrauterine or intrapartum demise. I would want to confirm what was the mode of her delivery for the previous.
Was normal delivery.
Okay. So yeah, we would induce her in the consultant-led unit as she is high risk. And does she have any risk factors for to avoid prostaglandin at all? She's
She has
diabetic.
just gestational diabetes, diet control.
That's fine. But she is BMI 36, so we would also explain her the failed induction of labor, chances of operative delivery. Um, and I don't know if the baby is large, LGA baby, as she is diabetic, but it's controlled, I know.
There is Hira, if I have not told you any positive findings, so assume everything is normal, okay? Baby weight
Yeah.
is assume everything is normal.
Okay. Yeah, so then I would want to do continuous CTG monitoring
Mm-hmm.
in a consultant. She will be delivering in a consultant-led unit as my patient is Gavlatri Para 1 with no alive issue, 39 plus 1 weeks, with reduced fetal movements. She's a high-risk patient, and I will plan the induction of labor in a consultant-led unit. And I would counsel her for what to expect during the induction of labor. I would counsel her about the failure of induction. I would counsel her as her BMI is on the higher side, which is 36, she may end up in failed induction, possibility of difficult labor, um, shoulder dystocia as well. And I would actually discuss it with my consultant whether we should go for elective cesarean or we should do a planned induction of labor. As I don't want uh, uh, as we want like a healthy outcome.
Why reduced fetal movement matters? Why are we concerned?
We are concerned because she is diabetic,
Hmm.
um, and she is 39 plus 1 weeks. I mean, if it was less than 39 weeks, then we would, do CTG. If CTG was normal, then we would have taken her no later than 40 weeks. We would deliver her before 40 weeks, but she is more than 39, so we would have to deliver her. At this point, it matters in a sense that she has an IUFD
Hmm.
previously as well. So at this time, we don't want to, gain a few days and then lose something, the outcome, like a worse outcome. So I would just want to deliver her now.
Okay. When your patient come with the reduced fetal moment, what is the indication for ultrasound?
We would have to do bedside ultrasound for all of the reduced fetal movement patients.
For
But
all?
for all,
Okay.
we have to do four things. We have to do a symphysis fundal height. We have to do handheld fetal heart with pinard or whatever with the stethoscope, or we have to do CTG more than 28 weeks or 26 weeks, all of them, and a bedside ultrasound to do the Leica and to do the movements. And then if something is wrong among all of this, then we go for a departmental scan within a day. At least that's what the
Thank you, Hira.
idea
Thank
is.
you. We took 1 minute extra,
Okay.
but I didn't stop you because I wanted to do this question. It was an extra. You finish your task in the desired time. Very beautiful. Everything was up to the mark. In the medication, when you were asking, ask any sedative medication or narcotics or any sleep medication. Okay. You
Okay.
admitted this patient, you realized the severity. For GDM, you already told me because diet control, so we can't wait for the 40 weeks. But my patient has the risk factor of IUFD previously,
Yeah.
so it's a high risk. So I will do the bishop scoring, and then I will do accordingly, I will induce. Right? So you involved your consultant. That was beautiful. Induction of labor was needed. Patient need to be admitted. Tell her the risk factor for the mom and for the baby. For the mom, GDM plus reduced fetal moment, she can have the again suffering. IUFT can be repeated. Even for the baby, there's a higher chance of the stillbirth again. So you don't want to repeat this. You have to deliver her safely. Otherwise, if I don't give you this IFD risk factor, you can send her home after doing the bishop scoring, checking the bishop scoring, and doing the intermittent heart auscultation. Send her home. Then, if this is the recurrent fetal reduced fetal moment, then we
Then we
have
will
to.
deliver her.
Yeah, yeah.
Yeah.
But here, one risk factor was enough. Hira, this I had little bit concern. Elective cesarean versus planned induction. You don't do that. Previously, it was delivered
No?
normally. Sorry.
Okay. Yeah. No, I'm asking.
Previously, it was delivered normally. So don't mention this like for the happy outcome. Induction has a bad outcome. Not at all. My mom may say patient can
Dr.
continuously.
Saba, look at her BMI 36. She's GDM. She has IUFD.
Hira, I told you
No,
this part for
I'm
me.
asking you. Yeah.
Listen, my darling. This part was for me, and I told you only diet control GDM. I understand you saw this BMI and you were start talking, but I told you this box is for you. From this,
Okay.
from this,
Okay.
I know it's a little bit confusion. Next time, I will make my box and your box separate. Okay, so I told you this one only na. I wanted to keep it in a simple case, so it was
Okay.
beautiful. If you do the BMI 36 week, just say in a case she has the higher chance of failure of induction because of her BMI, I will induce her with the low threshold of cesarean.
Okay.
Never outweigh like this. This is the safe, this is not safe. So what do you know, in Ireland and the UK, even my friend delivered in Australia, she had third degree vaginal tremor. Can you trust me? They just give her paracetamol. She was calling me again and again. I'm in severe pain. They don't give any medicine. My other friend delivered in Ireland. She told me she had cesarean. They did not give her. They just give the antibiotic at that time for the discharge. They don't give antibiotic. You know this. We here in
Yeah.
Pakistan, what we have tendency, we give them augmentin. Even for the normal delivery, we do a lot of medication.
So, Dr. Saba, this is I delivered my both babies in Canada.
Mhm.
They do the same. But the thing is that I think the environmental or all of the other factors are very, very different. Hygiene, the environment, the
Yes,
technique,
the
the
matter,
aseptic measures,
the matter,
and all
the
of that. So I think for a place like Pakistan or all of the developing countries, it's a must.
yeah. Yeah, you're very right.
Yeah.
But since we are preparing for the island, so for them, no need for giving these things. So my purpose was saying this. They don't think cesarean is a good thing. Even the patient cries in the labor, they let her deliver normally. They let her deliver normally until unless there is real indication for cesarean. They won't pick the cesarean first. So they love as an MRCPI candidate, as an ST3, ST4 level. Students should know the induction of the labor, and students should know what is the low threshold for cesarean and just involve their consultant. Consultant will decide like shift for the cesarean if there any difficulty comes in. You have already do the continuous CTG because of our CTG, GDM and previous risk factor, right? Rest, everything is perfect. Just don't compare them, okay? You in the history you asked about these risk factor. I love that. Preeclampsia, smoking, obesity, diabetes, advanced maternal age can also be a risk factor. Currently, you asked from last night, did you notice it first or previously before? That was a good question. Associated symptom, you covered just trauma. Ask about the trauma as well. Okay. Any growth concern she previously had in this pregnancy, medication she is using, and then any thing on her anatomical survey or before that she has been told, because the previously she has, this was in your sheet, placental insufficiency.
Yeah.
So this time you have to inquire about the placenta localization and Doppler studies if she has been done or not. These patients with the reduced fetal movement, is very important to ask about the narcotics use or domestic violence and trauma.
Yeah.
Yeah, because when we will do the domestic violence, the patient won't be having anything. Otherwise, she will say reduce fetal movement again and again.
Yeah.
Examination, nothing was significant. Just CTG. First, we will do intermittent auscultation. First, what we do, we take the history. If everything is good,
Yeah.
or she really has the reduced fetal movement, we do the intermittent auscultation and we give her the kick chart. Okay. If it is good, then no risk factor in the detailed history, send her home. Tell her the red flag sign, come back if it is episode repeat. If any problem in intermittent, no, it's not intermittent auscultation. What we say, Doppler?
Handheld.
Handheld Doppler. Yeah, sorry. If handheld Doppler is having a problem, plus minus, you go for the ultrasound. If no fetal heartbeat, then real time ultrasound. If any risk factor in the history, risk factor is positive, like in your case, so here you have to do the ultrasound and Doppler again. There was the risk factor. Previous IUFT and GDM. She has the risk factor, you did the Doppler. And intermittent auscultation here with the intermittent auscultation positive, we do the CTG.
Yeah.
And then
So the new guidelines for they say that more than 28 weeks you have to do CTG for all of them.
Yes, for all of them. So here it more than 28 week, minimum 20 minutes CTG, okay? For all women, mandatory, as you already mentioned, okay? So like examiner should hear from you 20 minutes CTG, I will perform for her, or I will do the CTG. And if the CTG is bad, again ultrasound indication. If the CTG is good, she has the risk factor, again is ultrasound indication, okay?
Yeah.
Then you asked here, Hira, this was little bit couldn't come as properly flow. Make the flow. Maternal cause, this narcotic, anxiolytic, hypoglycemia, smoking, or increased activity level, maybe. Fetal cause, normal sleep cycle number 1. Then any fetal pathology like growth restriction or hypoxia. Because I asked why it is significant. Fetal movements are significant because they are the first ever sign of fetal hypoxia and compromise. First sign. That is the significance. That's why we become alert. Then third cause is placental. You already mentioned. Then amniotic fluid is another cause. And even the picture, high BMI. Big mommy, big baby. And
I
then
think I mentioned, but I was not very
just make compartments.
fluent.
Maternal cause, maternal cause, this is this, fetal cause, this is placental, this is. For the structured discussion, they prefer like a proper coming the bullets. An emergency situation, it can be like a first sign. So I'm like vigilant for my patient. Then this is the examiner question. This slide I made for the examiner question. They asked you the patient had abnormal CTG, what you will do? Immediate senior obstetric review. Involve your senior everywhere. Then you will do the ultrasound. You will do the bishop because she's at 39 week. You will admit her. Ultrasound, you will exclude any other pathology. If it is normal, 39 week, induce her and call the neonatal team. Then high risk
Yeah.
women are like our case was this, right? We made her high risk. Obesity, diabetes, and IUFD. Obesity I skipped, but again, these two risk factors are for high risk. So what you do? Low threshold for induction of labor. Hira,
Low threshold.
low threshold for induction of labor and like backup for the cesarean. Low threshold for
Yeah.
cesarean. Okay. These
Yeah.
line increased surveillance, senior clinical involvement in decision making, which you already done.
Yeah. Increased surveillance is like CTG, right? Continuous
Yeah,
CTG.
continuous strategy. Yes. And we don't leave her alone. One-to-one care, partogram, like
Yeah.
you add on things. Keep on and intrapartum, you will do her blood sugar level 1 hourly, this and that.
Yeah.
It should be so you have a lot of points to speak on this. In 39-week here, if there's no risk factor but persistent, again this same
Yeah.
management. What is recurrent? More than 2 episodes, two or more than two. This was Hira. This was when you were telling her maternal and fetal risk factor, recurrence of the stillbirth. The cause can be growth restriction, so that's why you went for an ultrasound. And previously she had placental insufficiency, so you rule out again these two things on ultrasound. And
Yeah.
this was our case. Previous IUFT, we managed her with the induction. This was why it is important, why it is matter, because this is the first ever sign of fetal hypoxia and compromise when ultrasound is indicated. Why? Same day ultrasound is indicated for the persistent reduced fetal moment and for those who have the risk factor and for the non-reassuring CTG or the recurrent reduced fetal moment. Or if on examination you find STA or reduced like or any risk factor you find in the history or in the examination, you do the ultrasound. But CTG for all.
Yeah.
Then role of induction, you already told me. Usually they mix up the induction guideline. Usually they mix up the VBAC guideline plus these
Yeah.
little things, IUFT, because these topics they don't test alone. So usually they make a mixture of them. Here, are you up for oligohydramnios or you want to do the circuit?
I'm just saying oligo because oligo would be like SGA, right?
Yeah,
Things
yeah.
around hypertension and diabetes and blah blah blah.
You want
So
to do
I'm
that?
just saying, no, let's do the red cell. And then
Yeah, that will be different.
you have energy and we have energy we can, or maybe someone will join. I
If
don't
you
know.
if you are tired, then let me know. I will like I won't overburden you. But
No,
it's
no,
your
it's
benefit.
fine.
Last time Monia
We
did
have
all
to
those
do it,
topics.
right?
Yes.
Yeah,
You will
yeah.
do it, inshallah. Okay, it's just a 10 minutes task. How
Yeah.
you want to do as a structured discussion or SPT? I keep it as a structured discussion, by the way.
Yeah, that's fine. We'll do it.
Because SPT we did last time we only did SPTs. All the anomalies I made SPTs. Okay, so let's start
Yeah.
entering people.
Hi, my name is Dr. Hira, and this is my exam sticker.
This is okay. Read your scenario. This is your scenario.
Okay. So my patient is 29-year-old woman, guarded to Para 1 at 28-week gestation. Came in for routine antenatal care. However, I have the blood results which show she's RH negative, and the husband is RH positive, and she does not have any um, antibody screen. Antibody screen is negative. Um, So I would want to start off by asking, after asking the demographic information, confirming the information I have. I would ask her about current pregnancy, if there is anything unusual that she has noticed in terms of um, sh like shortness of breath or any changes in the size of the abdomen, big or small. I would ask any episodes of bleeding, pain, or fluid leak from down below. Um, and I would confirm from her the blood group as well, as it's O negative. I would ask her if she has received any um, uh, um, injections the for the sorry,
Prophylaxis.
NTD,
Prophylaxis.
yeah, for prophylaxis. And also, I would ask if she has had any titers done before, as I see that she has done it once, and I would ask like when was it done, at what gestational age, and is she undergoing any frequent ultrasounds or additional ultrasounds and surveillance. I would ask about her previous pregnancy, what was the mode, and were there any complications? What was the blood group of the baby born? And again, did she receive any NTD prophylaxis after birth? I would also ask um, um, about the any complications that had occurred in the previous pregnancy. I would ask about the any medical conditions that she had, any medications that she has been taking, any allergies, and also any surgeries down below the tummy. I would also ask about the I would also ask about her smoking alcohol support at home, and also about any restrictions of blood like Jehovah's Witness. Um, and I would mention if there is anything of that sort in the notes. And then I would want to examine her.
Okay. What are the consequences of the O negative blood group and the partner is O positive? What are the consequences for this?
She can have there is a high chance that the baby could be Rh positive, and in that case, the antibodies from the antigens from the baby can be transferred to the mother, and that could cause maternal fetal that could make the antibodies, and those antibodies can cross the placenta and cause the fetal maternal hemorrhage, which can lead to fetal anemia. And that can lead to a bad fetal maternal outcome.
Like you told, fetal anemia, what are the other hemolytic diseases of the fetus? What are other consequences for the baby other than anemia? We can have anemia and
I forgot altogether.
immune hydrops
Yes, immune hydrops
and consequences of immune hydrops. Please tell.
is
We did last time immune hydrops.
immune hydrops. There are grades, right?
Yeah, but what are the consequences? Hydrops can lead to the death. Postpartum, if it deliver, it can cause the jaundice, then kernicterus. So all these spectrum is hemolytic diseases. Okay. So as you already told the focus history, what should has been done pre-pregnancy for this patient?
Pre-pregnancy, she would have had counseling first in the last pregnancy, and she would have had the titers done for the NTD. And if she did not have any antibodies, then she would have been given the NTD prophylaxis, which would be like we we do it around 28 weeks.
So pre-pregnancy, you do it or not?
We don't do pre-pregnancy prophylaxis, but we only do the titers.
Okay. So what are the sensitizing events? Hira, my daughter is here, so I will open the door, but you continue. Sorry, you can come. Sarah, you can come. Sarah. So what are the sensitizing events for which you have to cover NTD?
Yeah, so start from in the first trimester, there is MTOP, STOP. STOP, all of the patients would receive NTD, and in MTOP, if the patient bleeds really, really heavily, and if the patient has a lot of pain, then we give at least 250 international units if she's less than 12 weeks. And if she is between 12 and 20 weeks, we give 625 units. We do it if the event she has heavy bleeding, then we would do it like every 6 weekly interval, 625 units. And if she's more than 20 weeks, then we'd give like 1,000 to 1,500 units. And that too we would do like at 6 weekly interval if the bleeding is heavy. And that could be due to trauma as well. Or if she's undergoing any invasive procedures like amniocentesis or CBS, in that case as well.
Sorry, my mic was mute.
That's
Okay.
okay.
So what is the dose for NTD for this? Mhm.
For this patient, it's she's at 28 weeks, so between 1,000 and 1,500 international units.
Okay.
But we have to do the titers first.
Okay. So tell me the management of this patient from now onward. You will do her NTD prophylaxis right now.
Yeah.
Then what you will do?
And we will do the serial ultrasound scans as well.
Mhm.
For the fetal growth scans. Restart between 16 and 24 weeks, every 4 to 6 weekly. We will, so depending on like what the titers are, if
So the
she comes
patient,
out,
okay, the patient had a trauma and her NTD titer is now 15 international unit. What you will do?
antibody titer is what?
15, yes, 15.
Okay, now we will give her the NTD.
Okay, then
Then we will do the fetal-maternal hemorrhage testing, which is the Klubetzky's test and also the MCA PSV Doppler.
yes.
And if it is more than 1.5, then we would send her to the maternal or fetal maternal unit, refer her there, and they will do the serial titers, the scans weekly. And if she happens to have the MCA PSV more than 1.5 and she is less than 34 weeks, then the fetal maternal unit obviously and the consultants decide for the fetal blood sampling and the intrauterine transfusion. However, if the patient is more than 34 weeks with more than 1.5 MCA PSV, then we would have to deliver her.
Okay. When you deliver this patient?
The patients with the positive
IUT.
titers.
Yes, and IUT, intrauterine transfer has been done. When to deliver?
No later than 34 weeks, I think. After 34 weeks. No
Yes,
later than
35 to 36. Yes.
Yeah. Okay, 35 to 36. Okay.
Okay. And how you will do? What is the any specific requirements for the labor?
Specific requirements for labor.
Yeah. What is
I
the
don't
mode
know.
of delivery and any precaution?
Mode of delivery and any precaution. You wouldn't want any fetal trauma.
Hmm.
The mode of delivery won't change because of this, no?
Hmm.
If there is obstetric reason for operative delivery, we would go for that, but otherwise the mode of delivery won't change.
Hmm. What precautions?
Um,
Multidisciplinary team which you want on board for delivery?
we want senior obstetricians,
Mhm.
and as it would be in the fetal-maternal unit, that would be
Mhm.
like by the fetal-maternal specialists. You would
Mhm.
have the neonatologist, you would have the
Yeah.
hematologist, and the anesthetist as well as usual. Is there anything else that you have to do that I
Okay.
would?
What are different types of antibodies?
There is anti-C, there is anti-D, anti-K, and E.
Okay. What is the importance of anti-K and how you manage it?
Anti-K is a very bad one. And even at any levels would be bad, and we have to refer the patient as soon as it becomes positive to the fetal maternal unit. And again, they would do the serial titer scans.
Thank you so
Uh,
much. Thank you. Thank you.
and
Thank you.
see. Mhm.
I give you 1 minute extra because of disturbance at the back end. It was beautiful, perfect. Just anti-K is not bad because it is structured discussion. So you can say, and according to
Oh
the
no, yeah, it's significant.
yeah, it's a significant, it's a lethal, it is
It's
most
lethal. Yeah,
dangerous,
fatal.
detrimental effect. It's like a killer. Like
Yeah.
use a little bit those words and use the reference of guideline again and again. You were speaking what you were speaking. Those were not your words. You were speaking guideline. So tell me
Yeah.
according to guideline, according to guideline, according to guideline. If
Yeah.
your structured discussion is going well, you have to be top score by saying this according to guideline. If it is not going well, then you struggle for write and down. Then this perfection should not be part. Focus should be like
Yeah.
normal content. But you were doing mashallah super perfect. So tackle like for highest score. Say again and again according to the guideline. Okay, according
Yeah.
to the Irish guideline, according to this and that. Hira, this thing, when the structured discussion comes and they give you a scenario, you read the scenario, what is called the situational awareness, right?
Yeah.
Like situational awareness, background of that patient, and assessment and risk factor or recommendation. So the Sabar tool is for the circuit. Here you told me Gravida to para 1, 28 weeks. Like if I say how you manage or how you will proceed. Gravida to para 1, 28 weeks presented with O negative blood group. Husband is Rh positive. Patient has anti-D negative yet. So my patient is having the B negative blood group or the alloimmunization, or she is at risk of hemolytic disease of the fetus and newborn, and I have to prevent that. Like just
Mhm.
tell one liner diagnosis. What is I spoke a little bit longer, but you can summarize one liner. Okay, first
Okay.
tell the diagnosis. Okay, then you start what you are, where you are present. If they has given you, you are ST4 in the antenatal clinic, so you can say I have in my antenatal clinic I am an ST4 today, so I received this patient and my probable diagnosis is this.
Mhm.
This line can immediately catch the attention of your examiner. Like this girl is stand out. She has
Yeah.
a potential. She know what she's gonna do today.
Yeah.
Then the hemolytic here you mentioned very beautifully. You told the mechanism why it is happen. You can tell that she has the anti-D, but for these patients, when they has anti-D, we have to check other antibodies as well, right?
Yeah.
So you rule out other antibodies. This spectrum, you was little bit lack of the words for this hemolytic diseases of the fetus and newborn, and
Yeah. Oh, okay.
she don't have anything now, but
Hmm.
she has the risk of these. So
I got confused. I said, what else you want to
yeah, I
do?
was I was saying, fetal and maternal risk. Fetal risk are most important. I loved it when you asked about the previous baby and any complication. Ask about the jaundice and neonatal admission for that baby or any transfer you asked already, but mention
Mhm.
the jaundice as well. Okay,
Mhm.
NTD because NTD can cause the jaundice and
Yeah.
connectaris accordingly.
Yeah.
So,
It's
when you
not
start the
transferred.
focused history or how you approach your patient clinically, then clinically approach means history and examination. Ask on number one, current pregnancy detail, then number two, previous, and number three is other systemical history, right? So here,
Yeah.
what you do for the current pregnancy, any episodes of bleeding, any trauma, any investigation has done so far. How's her movement? How's the tummy size? Maybe she has like immune her drops. How you catch these babies?
I
They
think
have the certain.
I did ask about the increased
You
radicals in
did,
the
you
side.
did.
Yeah.
I'm just telling for the
Yeah,
other
yeah, yeah.
students.
Yeah,
Then
yeah,
obstetrical history, you already covered all the point, and then you really ask for the NTD previously given or not. You did it.
yeah.
Medical and surgical history, just again ask any blood transfusion or any other thing. But Hira, for pre-pregnancy, we don't do NTD until unless there's sensitizing on. What we do pre-pregnancy, we do the pre-pregnancy counseling. Oh, sorry.
Okay.
We do the pre-pregnancy counseling. We tell them the risk of hemolytic disease for the fetus. If the
Mm-hmm.
previous baby has, then the recurrence risk. We tell the
Mm-hmm.
risk factor for the mom, and
Mm-hmm.
we check the partner blood group, which in your case already was checked. So
Okay.
pre-pregnancy, we do the counseling. If NTD is positive, then pre-pregnancy we send them to the joint hematologist and genetics. They will plan, they will do their high risk pregnancy and then consultant led units, like planned pregnancy, then they will have. If previously, because if previously the baby is having the positive or she has done it, there's a higher chance of the recurrence in this pregnancy. And when she is in the pregnancy state, she already had NTD titer positive.
So we'll just do the counseling. We'll explain
Counseling,
the
tell her
maternal
that,
risk, the
yeah,
fetal risk, the partner testing, and if anything come positive,
then
and
refer
if
them.
she has previous jaundice baby, then we'll refer her to the joint
Refer them.
hemolytic and genetics.
Yes, yes. For these patient, fetal medicine unit and the neonatologist team and pediatric team, they must be standby and on board. Doses 28 weeks, you already give her 1500 unit. The question was that next she at 29 weeks she has the trauma. Like if you ask the detail of trauma, I will tell you it's a little bit trauma, and but the baby and everything is okay. So you repeat the NTD. You did
Yeah.
already. You repeated,
Yeah.
and now onward take her the severe fetal surveillance from now onward because she has a sensitizing event. Now you will check the NTD level. I guess 2 weekly, right? Before till 28 week you were doing the 2 to 4 weekly, 4 weekly, and now you will do the 2 weekly.
2 weekly. Yeah,
And
NTD
again you
level
did the
scan
MCA.
and
Yeah,
Doppler.
again you
Yeah.
did the MCA 1.5 mom. You refer to fetal medicine unit and IUT. Beautiful, beautiful that part. What are sensitizing events you already covered, and then this part more than 15. You did MCA Doppler 1.5 mom. You refer to FMU, detailed anatomical survey, and again fetal blood sampling and IUT. And for the IUT, we deliver them at 35 to 36. For these patients, I was asking the mode of delivery. First, you make your MDT, stand by your FMU consultant and your neonatologist. Decide her mode of delivery because she has already taken IUT, so not 36. You will decide at 34 to 35 week. Then low threshold for cesarean. Why? Because they are already anemic baby. They won't
Yeah.
stress. They won't tolerate the labor. Plus, you are delivering them early, prematurely. You are delivering them. So
Mhm.
usually mode of delivery is cesarean for them. But if patient want, if then a short trial of labor with the vigilant precaution can be given. Never say yes or no. If the examiner
Mhm.
asks the cesarean patient cannot have normal delivery, don't say no, she cannot because of anemia. You can say recommended is cesarean, but this can be considered with the vigilant precautions and trial. Okay.
Mhm.
OSCE is all about being diplomat. It's now never it's a
Yeah.
great
But you have to have knowledge to become a
yes,
diplomat.
diplomat, and you have to justify your statement.
Yeah.
Okay, so saying yes or no is little bit not giving the margin. Keep in a gray zone. Examiner could not have an idea what this girl gonna do.
Yeah, they cannot get inside your mind.
Okay, Hira, thank you so much. Thank you so much. Next we have the oligohydramnios.
Let's just do it and finish it. Whatever it is. It's long case, yeah?
Long case. You want to do it long case or structured discussion? Your choice.
You tell me. I'm okay with anything.
No, for
You
your
tell
for
how
your
much
practice.
energy you have.
I have energy. I
We can
have
do
energy.
long case.
Okay,
Yeah,
then
we can do long case then.
like I'm concerned about your energy because I have to stay silent and you have
Yeah,
to speak.
yeah.
Okay, let's start it, my dear. Start.
Hi, my name is Dr. Hira, and this is my exam sticker.
Okay,
I'm gonna
continue.
read the scenario. Okay. Okay. Hi, I'm Dr. Hira. I'll be your doctor today. May I confirm your name and age, please?
My name is Amanda and I'm 30 years.
Thank you. Is it okay if I call you Amanda?
Yes, doctor.
Okay, Amanda. I would be asking you a few questions about your pregnancy. And where I will do some examination. I have set of ultrasound findings. Can I just quickly confirm the name on it? Is it Amanda, 30 years old? Yeah.
Yes, doctor.
Okay, thank you. We will discuss the ultrasound findings as well. I'll do a brief examination and then we'll take it from there. Is that okay?
Yes, doctor.
And if you have any questions in between, you can stop and ask. Okay.
Okay, doctor.
All right. So, Amanda, is this your first pregnancy?
Yes, doctor.
Okay. Is it a planned pregnancy?
Yes, doctor.
Okay. Congratulations.
Thank you, doctor.
How has the pregnancy been so far?
It's going good, doctor, and everything it was okay.
Mhm. I understand that you have reduced fetal movement since yesterday. Is that right?
Yes, doctor. My baby was not moving well, and I'm very concerned.
And so, when you say not moving well, how many movements have you felt in the last
But
24
like
hours?
1 or 2 moments since the whole night, just 1 or 2 times, I feel a kick.
Okay, I'm sure it must be concerning, but we are here to help you. And let me just give me some more time, and we will see what we will do. Okay.
Okay, doctor.
Okay. So this has happened for the first time, or has it happened before?
The before moment was fine.
Okay, the movements were fine. And have you noticed any changes in the size of your tummy? Has it gone small or large?
I don't know, doctor. They say like my tummy feels smaller every time my OBG she get concerned about my tummy size. She says smaller.
Uh, and um, have you been going to your OBGYN frequently?
Yes, doctor. And today they referred me towards you. They said there's some problem with ultrasound as well.
Mm-hmm. I see. Okay. So, could you recall, like, since when did you start noticing um, the smaller tummy, or when did your doctor start telling you that?
It's like from the beginning, doctor.
From
Uh,
the beginning.
yeah.
Okay. Okay. Is there anything else like pain or bleeding from down below or water leak from down below?
No, doctor.
Okay. And is there any illness that happened, like fever or discharge from your vagina, or like any illness during this pregnancy up until now?
No, doctor, but in the start of pregnancy, I had like immense vomiting. I cannot tell you. There was so much vomiting, and even they kept me admit for 1 day.
Okay. And now the vomiting is settled?
Yes, doctor, it was settled at I guess 6 months. I was okay.
Okay. And did you tell you any specific cause, or was it they told you it's just because of the pregnancy hormones?
I guess they said like everyone feel this way.
Oh, okay. And otherwise, your dietary habits are okay? You drink and eat normally, or any restrictions? You drink
Yes, doctor.
water, liquids, and your fluid intake is perfect.
Yes, doctor.
And other than that, no recent like episode of diarrhea or vomiting.
No, doctor.
Okay. Well, how about any history of high blood pressure during this pregnancy or before this pregnancy?
Doctor, I am a hypertensive patient, and I have raised blood pressure even before pregnancy.
Okay. And what do you do for that? Are you going to your regular GP taking medications?
Yes, doctor. I take them regularly. I even when I was pregnant, they changed my medication. I used to take
Mm-hmm.
an Alapril,
Mm-hmm.
then they changed the medication.
When did they change?
At my 8 week visit.
Okay. And right now you are taking the medication for the hypertension regularly.
Yes, doctor.
And what about, did they start aspirin at all?
Yes, doctor.
And you are taking that as well.
Yes.
Great. Your blood pressure readings are fine now? Do you do it at home?
Yes, doctor. It's 130/80.
Okay. And any history of high blood sugar as well?
No, doctor.
Okay. Um, and pardon me for asking this, do you smoke or drink alcohol?
No, doctor.
Okay. And additionally, just one more thing, pardon me for that. Any recreational drugs like
No,
marijuana,
doctor.
cocaine? No, okay, great. Um, thank you. Any medical, and sorry, when was your last period? I know you were 36 weeks and 1 day pregnant, but do you remember the date?
Yes, doctor. It was corresponding to my date, 36 week.
Okay. Um, all right. And any sexual, pardon me for asking this, any sexually shared infections during this
No.
pregnancy? No. Okay. Uh, and are you up to date with your smears?
Yes, doctor.
Okay. Thank you. So any other medical conditions apart from high blood pressure?
No, doctor.
Okay. Any medications apart from your blood pressure and aspirin? Are you taking folic acid?
Not
Did you
folic
take
acid.
folic acid or multivitamin?
In the beginning, I took the folic acid, but now
Mhm.
I'm taking my tonics.
Great. Are you allergic to any medication?
No, doctor.
Okay. And any surgeries from tummy down below?
No, doctor.
Okay. And how are things at home?
Everything is good.
Great. And what do you do for a living?
I am a teacher.
You are a teacher. And did you change your job recently or any stress at work?
Not.
No? Okay.
No, doctor.
Okay, great. And any history of having um uh, uh, any family history of having problems with pregnancy or having smaller babies?
No, doctor.
Like, did
But
your mom ever told you that you were small or your siblings?
no, doctor.
Okay. And your husband is of a normal height, or people tell them it's
Yes, doctor.
smaller?
He's taller than me.
Okay, great. Um, so pregnancy with teaching and working could be sometimes challenging, as this is your first pregnancy as well. You can be excited and overwhelmed. So how has your mood been?
It's perfectly okay. I'm very excited, and today I'm really
That's
concerned
good.
about my baby.
Yeah, I understand. Um, I'll come back to it shortly. Um, um, so, and what's your blood group, Amanda?
It's O negative, doctor.
Okay, I will note that down. And any restriction for like blood transfusions?
No, doctor.
Great. And what's your BMI? Height to weight ratio, if you know?
It's 32.
It's 32. Okay, it's a little bit on the higher side. Have you tried to try any specific diet or um, try to, do some activity to um, bring it a little bit down?
No, doctor. As I feel myself a good way, and even because
Mm-hmm.
of my pregnancy, they asked me not to do any crash diet or something. So maybe after delivery, I can consider.
Okay. Yeah, if you'd be interested, then I can connect you with a nutritional support. Okay, great. So thank you for answering my questions, Amanda. I would want to do a quick examination on you, if that's okay.
Yes, doctor.
Okay. So in the presence of chaperone, I would do the prerequisite hand sanitization technique and also the proper exposure um, for the abdominal obstructive examination. But before that, I would want to do a general physical check, including the BMI and the blood pressure monitoring, oxygen saturation, as well as the for the general pallor signs of pallor or cyanosis. And I would come to the obstetrical examination. I would want the patient Amanda to be exposed from the sternum to mid-thigh in the presence of chaperone. Standing on the right side of the patient, I would want to look at the contour of the abdomen, particularly the symphysis fundal height, as my ultrasound finding shows they have AFI to be less and DVP is less as well. Although the size of the baby and the Doppler is normal. So I would check the lie, the fetal heart rate, as she has reduced fetal movements as well. And the presentation of the baby as she's 36 plus 1 week. She does not have any active vaginal complaints. Sorry.
No.
So I would defer the first speculum or vaginal examination. Uh, uh, I would want to uh, order
An
some
examination
investigation.
finding. An examination finding you want from me?
What was the symphysis fundal height for the patient?
It is 34 centimeter.
And what was the blood pressure?
Blood pressure is today 140 by 85.
And what is the fetal heart rate?
Fetal heart rate are fine. It is 132.
Okay, I would want to do a CTG for this patient for 20 minutes as she has reduced fetal movements. She is 36 plus 1 week.
CTG is reactive.
Okay. I would also want to get a set of baseline investigations for blood count. No, examination. We are still at examination, right?
Yeah. Anything
Yeah.
else?
Okay.
Okay.
I want a dating scan. An anatomical scan. I think that comes in the investigation.
Dating scan is correlating with the date, and detailed anomaly scan doesn't have any significance anomaly.
Okay. Any reports of previous Dopplers, because she's been visiting the GP as well.
Doppler is done
OBGYN.
normal.
Okay, and may I know like her AFI from the previous scans?
Previously, AFI is 2 centimeter. AFI is 5 centimeter and DVP is 2 centimeter.
Okay. So I see that it is reducing to the report I have for today. It's 1.5 centimeter and from 2 centimeter and 4 centimeter from 5 centimeter. So
Anything else?
I want the PIH profile.
Yes, thank God. What you want? What you want in that?
I want LFTs. I
LFT is
want
normal.
PTINR.
Normal.
I want from the full blood count, I want the platelet count, hemoglobin.
Platelet count are 100. Hemoglobin is 11.
Platelet count 100 and okay. And I would want to know
Hera, ask renal function test from me.
renal function test.
Chronic hypertension.
Yeah, renal function test. Serum electrolytes also.
Renal function test normal. Serum electrolytes normal.
Okay.
And what else come in PIH
Urine
profile?
dipstick.
Yes, urine dipstick. She has 1 plus
Proteinuria.
protein. 1 plus
How much?
protein. 1 plus. 1
Okay.
plus protein, blood pressure 140, 85. Okay? Summarize your case.
So I have Amanda. She is 30 years old, primary gravida at 36 plus 1 week with complaints of reduced fetal movement since yesterday. She's a known case of hypertension. Even before getting pregnant, she was on ACE inhibitors, which was changed to a pregnancy favorable medication, and she was started on aspirin as well. Her current blood pressure is 140/85. CTG is normal. She's O negative. From the history and examination, there are no risk factors other than hypertension itself and being primary gravida. And her physical examination shows a reduced fundal height of more than 2 centimeter. She's at 34. Her fetal heart rate is okay. CTG is reactive. Her pregnancy corresponds to the dating scan. Detailed anomaly scan was normal. AFI has been reduced from the previous scan from 5 to 4, and DVP has reduced from 2 centimeter to 1.5. Her PIH profile, her PIH profile is normal. And she has urine protein urea of +1. Renal function tests and electrolytes are normal. So Amanda has oligohydramnios, likely due to placental insufficiency, as she has reported herself as well that everybody has told her OB-GYN has always told her that the tummy is smaller. She has a reduced fundal height. And the likely reason of oligohydramnios seems to be the placental cause, as she does not have any history of torch infections as well. And congenital anomalies are ruled out by normal anomalies.
How you will manage your patient from now onward?
as she is 36 plus 1 weeks, and her FI is 4 centimeter. My plan would be and her blood pressure is 140 or 85, and urine protein is +1. I will do the CTG, which is normal. I would plan to deliver her around 36 to 37 weeks. If there is only isolated oligohydramnios and the Doppler and CTG remains normal.
Pick up, Hira. You have write the risk factor, right?
Yes.
Okay, give me a beautiful line. I can tell you the risk factor again. BMI 32, blood group O negative, reduced fetal movement last night, but now CTG fine. Blood pressure is 140/85 and +1 proteinuria with oligohydramnios. I guess
Yes,
there
so
are
I will admit this patient.
So how you start this? How management? Give
So,
me a management line. What is your aim? Tell me your aim. What you will avoid? What you're
so
gonna do?
I would. So my aim is a healthy fetal maternal outcome, and for that I would refer her to the consultant-led unit to be admitted there, um, as she has multiple risk factors. She has a high BMI. She has reduced fetal movement. She is a chronic hypertensive patient, and she has oligohydramnios in her first pregnancy. I would aim to deliver her by 37 weeks. During that time, we'll do daily CTG monitoring,
Mm-hmm.
Doppler, um, and uh, we have the pH profile. We can repeat if needed. We'll do the blood pressure monitoring as well. We will involve the neonatology team, and obviously my senior consultants.
Blood
And
pressure
we
is
would,
fine.
yeah, we will do the blood pressure monitoring,
Mm-hmm.
140/85.
Is your target.
Um, and no, my target is not that. We will continue with her medications that she is taking. Um, for this gestation, that's fine, I guess. We don't need to, increase or anything. 140/85. And I would want to basically deliver her by 37 weeks.
Okay.
And we will discuss the mode of delivery, which would be induction of labor.
Yes, tell me the story. How you gonna do that? At which week? MDT meeting? When you guys will meet up? Right now it's 36 week. It's a 1 week ago. So speak up those words. Take your patient to the labor, deliver her safely postpartum, and then come again.
Yeah. So
You're doing perfect. You're doing perfect.
yeah, so I will explain like what would be the I would explain her for I would counsel her for admission, then for the surveillance. I would tell her the process of induction of labor, what could be the what to expect and what could be the complications, both maternal and fetal. Um, which could be failed induction of labor, which could be prolonged labor, it could be um, fetal complications as well. It could be cord compression because of the reduced liquor. Could be meconium aspiration. And as the baby, and after birth, the baby could have problems with respiration. And there is a possibility of stillbirth if there is prolonged labor.
Okay.
And to avoid that, obviously, we are keeping her in consultant-led unit with continuous CTG monitoring, and monitoring for the signs of fetal distress. We will do Doppler as well. We will keep an eye on the blood pressure. And um, we will involve the neonatology team as well. And we will keep if any of the fetal distress signs appear, then we'll keep a low threshold for cesarean.
Hmm.
You want more?
Yes, I really want more. I want a contraception. I want to.
In the postpartum period, I will counsel her about, as we discussed, she has a high BMI, so we will discuss the visit to dietitian and also the nutritionist for making a plan for her to reduce the weight. We will tell her to do a 6 to 8 week blood pressure check as well. I would refer her to the general medical unit as well because she's the chronic hypertensive, so she would have to go back on enalapril. But no, during breastfeeding, we have to prescribe her medication which would be safe for her.
Mhm.
Um, was she taking methyldopa? If she was, then we have to change that in the postpartum period. And we would do like mm, uh, a postpartum visit as well, where we'll discuss the contraception. As she is on a high BMI, we would want to avoid the oral contraceptive pills. And we would convince her for LARC. And also she's hypertensive, so it's better for her
Thank
to
you,
take
Hira.
that.
Thank you. Time up. Thank you. Thank you. Thank you.
And
Hira, you know everything, but I don't know what happens. I have to give you a lot of prompts. It's the page is written in
maybe
front of
because
you.
I'm tired.
Yeah, I can see. But the right things were coming out. Just little bit. I have to give you prompt. Examiner won't give you. He will really be quiet
Okay,
all the time, and he will give you so much blank face. You feel like you are speaking. Nothing makes sense to
rubbish.
you. Rubbish. In fact, rubbish. He gives this type of looks. Even you are telling right, they will give you the this type of blank looks.
Plain blank look, yeah.
Plain blank look. So for this patient, when you were prompting the in her history, the currently pregnancy, you ask about the leaking, bleeding, reduced fetal movements, any contraction, because the oligo cause can be there.
Hmm.
Okay. So when you went for the obstetrical history, we don't have because she was the primary gravida. So ask you already. Did you ask about her any problem in nuchal thickness scan or anomaly scan?
I asked if there was any problem. I don't think so. I didn't ask
Antenatal. She
nipple
told you
thickness.
the tummy is shortened since the beginning
Yeah,
because she,
that's what I asked.
yeah. She is hypertensive. So hypertensive is baby weight is 3 kg, but she has the oligohydramnios because the blood pressure was
Yeah.
well controlled, but she has the oligohydramnios. So that was the cause. Other on you address the UTI symptoms and any condition. So here this was the cause in your patient hypertension plus hyperemesis gravidarum in the beginning. So in the beginning she is like a little bit prone, but right now there's no concern about the hyperemesis. That was a distractor. The risk
Hmm.
factor medication AC inhibitor they can cause the oligo, but she already changed. Otherwise, if she will be on enalapril, so you have to change this
Yeah,
enalapril.
I asked her when did you change? Yeah.
Yes, yes. So another thing, Hira, your pressure, a patient has right now her blood pressure was 140 by 85. In pregnancy, the target is nothing than 135 by 85. This is your target blood pressure for all the patient in the pregnancy.
Yeah.
The aim should be this. So it's little bit higher. So you have to inquire which medication she is taking, is whether she is taking labetalol or not. Which medication
Okay.
is taking, and you have to top up the dose. Just speak this word. How you
Okay.
start the management? This is your box of the risk factor. You enter is that my aim, as you said, my aim is to deliver the healthy fetal-maternal outcome. For that purpose, I will do the fetal and maternal side by side. The patient is already at 36-week primary GERDA, so I will tell her the risk factor for the mother and the baby. What mom can have the more increase in her blood pressure, or she can have the fits, she can have the like eclampsia sign and symptoms of that. So, and for the baby there as you already told, the risk of the stillbirth, IUGR, and the failure, mom can have the failure of induction. There's a lot of risk factor. O negative, because of the BMI,
Yeah.
she can have this. Because of the reduced fetal movement, baby can have this. Because of the O negative blood group, they have this. And 36 week, when you deliver them, you, if you inquire the partner blood group, you have to do NTD prophylaxis. Number one, you have to connect with her weight loss program. This was for her risk factor, and refer back to her blood pressure doctor. These were
I
the
didn't mention O negative. So.
one liner. These were the risk factors. So you tell the red flag sign: headache, epigastric pain, blurring of the vision, HELP syndrome, and eclampsia, and fits for the mom and for the baby. So you will admit the patient. Your aim will be 135 by 85, for which I will top up her blood pressure dose. I will do the blood pressure charting for her. The urine albumin is already 1 plus positive, so there is no need to repeat, but I will repeat the PAH profile. Daily CTG you mentioned, but I will ask my patient to keep an eye on fetal movement, because oligohydramnios with the hypertensive, she is really on the risk factor.
That's what I.
Then MDT you involved already. So consultant, nutritionist because of the BMI, then neonatologist and nursing care team and your staff. You guys will do the planned induction for this patient. Aim is to deliver at 37 week, but if the compromise, then obviously early. My patient has the more BMI, there's higher chance of failure of induction. So I will, she's oligohydramnios, blood pressure is raised. By the way, she has developed the preeclampsia, right? +1 positive.
Yeah, she has +1.
She has, yeah, superimposed preeclampsia on hypertension. So I will be vigilant, failure of induction, low threshold of cesarean, one line. But why don't go when she will be in the labor? I will do the continuous CTG, one-to-one care, charting, measure of blood pressure, and like when she will be delivered postpartum, there the baby will be handed over to the neonatologist. And postpartum, two things for the patient: blood pressure, as you already mentioned beautifully, methyl dopa you will do. Postpartum target is 140/80, so there is no like a strict monitoring, like but she has the +1 protein urea, so in the labor I'll be vigilant for the eclampsia or any other thing. Okay, I'll keep up the BP 1 hourly. Here, when you deliver mother for mom, I will say vigilant for the postpartum hemorrhage because of the BMI, because of this, and oligohydramnios. Beautifully, you mentioned the cord compression for the baby. So I will be again one line, low threshold for the cesarean. Continue CTG. The baby's hand over to neonatologist. Baby weight is good, but because of the oligohydramnios, they will do the monitoring of the baby as well. And for the mom, postpartum VTE prophylaxis. Never, these are scoring points. In any case, add them. VTE prophylaxis, early mobilization and hydration, then contraception, avoidance of OCP because of the two things. Number one, hypertension, and number two, BMI. You already mentioned. LARC method is preferable for her, and then postpartum follow-up to her the blood pressure. Just mention, if you had time, mention the what are the drugs are suitable. Enalapril, nifedipine, and what was the other one? Amlodipine?
Yes.
Okay, yeah, enalapril. Postpartum, you give these three drugs. Other thing, and anti-D prophylaxis. We already mentioned, and you connect her with the dietitian to optimize her weight before embarking to the next pregnancy. Next pregnancy, if you have time, like if examiner is still quiet, you go for 5 mg folic acid, high risk of recurrence, and then all that planned pregnancy, and avoidance of the NSAID in postpartum, by the way. Like, I'm not saying you have to speak all, because these are too much, not all. But keep on, yeah, it's too much, but keep on your story. In exam, hopefully I added 4 or 5 things. Yeah, don't stop
speaking.
Don't stop speaking. Please, please, please. Postpartum, and she should be sitting and feeding her baby, breastfeeding doing, and she's having and a sip of coffee and information leaflet. Then you are passed. My consultant used to say the patient should be having like this, a big tummy, and postpartum she should be sitting on a chair, breastfeeding her baby, and reading information leaflet. This is your journey to pass. So don't speak up. Whatever comes in, like this is the labor part, this is the postpartum part, and this is her contraception or breastfeeding part. Okay. So make a section in your mind and speak up on those sections. In the exam, usually I collected 4 or 5 risk factor. They will give you at least 2 risk factor. Must 2 risk factor will be must. There is no plain case. No plain
I
case.
think we should start. I mean, I do it on the paper, but it's all jumbled up. So I missed this time. I didn't miss the risk factor like the BMI and the stuff, but the first one I did miss
Yeah, this
asthma
time you did
and
well. You, it's well already like a repetition for you.
yeah.
Rest things you did it beautifully. You did the obstetrical examination. In the baby, ask when you ask anomalies, can ask about the renal agencies. You know, on posterior urethral
Yeah.
valves. If it's a structured discussion, if they ask you the causes, this is the favorite question in structured discussion. They ask the causes. You can say isolated, placental, and right now traumatic or iatrogenic and fetal renal agencies or urethral valve stricture or any problem with the baby or drug as well. NSAIDs.
Yeah.
What happened to my slide? It's not moving.
The slide is tired.
Yeah, like you. I'm so sorry.
No, why
No,
are you sorry?
baby.
You don't have to be sorry. How are your babies? Good?
Oh, they are not good actually.
How old are they?
No, they are just 3 months twins.
Oh my, you're still in kind of puerperium.
Yeah. I'm
Oh
still in
my
that.
God, look at you. Hey,
Okay,
thank you for
I guess
giving so much time.
it's okay. All my player.
I
I
think
just
we are done with our cases, right?
yeah, we're done our cases. But I just
Yeah.
want to end up.
It was so much fun.
Next time you won't be a
Yeah.
volunteer because I really catch you today.
No. I'm always a volunteer. The only thing is that I cannot be available on Sundays
It's
because
okay, Mira.
it's the weekend and you know how Dubai life is. My husband works all week, so we are with the kids on over the weekend.
You guys have
So
Sunday as a weekend.
sorry.
You have Sunday as a weekend. When is your
Yeah, we
weekend?
have Saturday, Sunday.
Oh,
Yeah, we have
here my
Saturday,
screen
Sunday
is
here.
visible.
Yes. No, it says Saba College,
Now check.
not your screen. Now your screen is visible.
Okay. So we were here for where we were in between
S
oligo, right?
factors. Yeah.
Sorry. Here.
Investigations.
Yeah, fetal renal investigation.
Causes.
Then admission criteria, surveillance protocol like CTG. If she is isolated, then CTG twice weekly, and the growth scan, antenatal steroid beyond 34 week we don't give. Your patient was already
Yeah,
36. If it is before, then you have to do that.
I have to
Delivery
do
aim,
that.
you pick it very rightly. Continuous CTG should be in the labor, and postpartum baby should be handed over to the neonatologist. Another thing, main causes of oligohydramnios, if it has been your because oligo usually don't come in the long case, it come in structured discussion. So this
Right.
slide cover all your question, causes, differentiation, and what how you manage, what is the Doppler, what is the prediction, and how you deliver them. Here are one
Okay.
thing, one take home message for you. Please try to skip when you induce or when you do a risk factor patient like oligo, SGA, hypertension, diabetic, more BMI, VBAC. Speak up that I will induce with the low threshold of cesarean.
Cesarean section.
Okay.
Okay.
I'll be vigilant for these
Mhm.
disease sign in the labor. If your patient had hypertension, you have to be vigilant for eclampsia. Your patient has GDM, you have to be vigilant for the shoulder dystocia. Even they don't have the big size baby, but the GDM and the more BMI, they are obstruction for the labor. So whatever they give you, just make a habit for making a 1 page. That will really help you because when you see the risk factor, you will do tick. Okay, I manage the BMI. Okay, I manage the O negative. Okay, I quit her smoking. I manage her this asthma. I haven't give her the painkiller. I mentioned her hypertension. I haven't given her OCP. Okay, that
Yeah.
will make your life easy.
Yeah.
OSCE is not difficult. It's just a trick. It's a game of mind and nerves. You have to be active that performance, that
Yeah.
25 minutes should be the best part. I don't want you to come out of the examination hall and leaving something in your heart.
Yeah.
Inshallah, you won't do. Any question, Hira?
Inshallah. No. So
Okay.
the next class would be on Sunday?
Yeah, it will be on Sunday, but no, not on Sunday, because I have to go for, I guess, yeah, it will be on Monday.
It will be on Monday, then I will attend, inshallah.
Okay, and
And
after that,
then also, Dr. Saba, I just one request. I don't see any discussion of time on the Telegram. Is
I
this
will
on? This is the only group, right? Which is
this is UMRCPI.
you,
Let me
yeah,
stop the
OSCE.
yeah.
That is the only one, right?
UMRCPI OSCE in the WhatsApp and in the Telegram. I just, if you don't have any time, just see the pin post.